I'm Miguel Villalona-Calero. I am the Director of Medical Oncology for the Ohio State University Department of Internal Medicine and the Ohio State University Comprehensive Cancer Center. Correct. We have had a lot of growth over the last 10 years. I've been here actually 11 years. So since 1997, the place had been logarithmically growing. And the initial emphasis was in the hematologic malignancies and to develop a leukemia and lymphoma program. And now the concentration will be in developing solid tumors, which of course are the most common tumors. And so this new division has been created specifically with that intent. And we are going to expand aggressively the subspecialties that we have within the solid tumor area. So we are 24 medical oncologists. We plan to make this at least 40. And I think the simplest way I try to put it to patients is that there are three things that are important when you try to decide what to treat the patient with, or if to treat the patient at all. The most important factor is of course the performance status, which is what is the level of physiologic activity of the patient. So for patients that are in bed, wheelchair bound, typically it is not a good idea for most treatments to be used. The second important aspect is the staging, as you mentioned. Patients that have a stage 1 or a stage 2 are more amenable to localized treatments like surgery, radiation, or a combination. And then patients that have advanced disease or locally advanced disease, and that's when the systemic therapies come into play. Now, the third aspect is then what is the type of cancer that you have? I tell the patients. And the type initially was based only in histology. And for many, many years, we used to just be concerned about if the patient had a small cell or non-small cell lung cancer. But then data keep coming that it was important to know the histologic subclassification of a non-small cell lung cancer. For example, adenocarcinoma versus squamous cell carcinoma. And actually, some of the chemotherapeutic agents that we use now, namely pemetrexed or so, appear to be more active in adenocarcinoma subtype. And then to make things a little bit more complicated and actually beneficial for patients, some of the molecularly targeted agents that have come into play, like bevacizumab, which is a vascular endothelial growth factor inhibitor, it is really contraindicated in a squamous cell due to the high propensity for bleeding in those patients. And then the molecular profile had make a home. And actually, at Ohio State, any patient that have an adenocarcinoma, we, provided that there is enough tissue, we do the molecular typing, and that is, we try to find if the patient have mutations in the epidermal growth factor receptor, or if they have mutations in KRAS. And the last thing that had come into play is a fusion gene called the ALK gene. And there are agents that are still not approved, but they come in down the pipeline that appears to be very efficacious for those patients that have the fusion genes. So the epidermal growth factor receptor is a receptor that the cancer cells have in the membrane. And actually it's expressed also in some normal cells, like in the liver and skin. And in tumors, it is very broadly expressed, and many different kinds of tumors like breast cancer, lung cancer, bladder. So the initial interest was to develop agents that will block this receptor. So there is a ligand that comes from outside, so it's the epidermal growth factor, so it binds to the receptor. And they came up with some agents that specifically will try to block either the junction of the ligand to the receptor or to block the activation of the receptor. So the monoclonal antibodies, which basically are what interferes with the binding, and then the tyrosine kinase inhibitors are oral agents, are small molecule inhibitors. They inhibit the activation of the receptor. So the story is that they try to develop these agents for all comers, all kinds of tumors, all kinds of lung cancers, and even other tumors, hoping that by blocking the receptor, you will block the tumor. And what they found is that that wasn't necessarily the case, and that only in a small proportion of patients did very well. And the rest of the patients, the tumor grew quickly or in a few months. So when they went back and looked at those patients that had dramatic responses, then they found that they have special kinds of changes in these activation areas in the receptor. It's actually in the intracytoplasmatic part of the receptor. And these changes or mutations, what appeared to do were to provide a better docking for the agent that came in, so you really could inhibit the signal. And furthermore, these particular tumors that have this mutation depended on this signaling for it to grow. So you not only cause a stabilization, but then you produce shrinkage. And in many cases, complete responses that will be maintained for many years. It's relevant to the pills, the oral tyrosine kinase inhibitors. You know, as I had mentioned before, there are two kinds of agents that interfere with EGFR. Ones are the monoclonal antibodies. What they do is they interfere with the binding, so they act extra cytoplasmatic. They just basically put like a little hat on top of the receptor, so the ligand doesn't bind. And then the other kind are these oral small molecule inhibitors that they will penetrate inside the cell, and their target is the intracytoplasmatic part of the receptor. So the mutations matter for the latter. For the small molecule inhibitors, there are two actually agents that are approved. One is gefitinib, no longer available in the United States, but approved in other places like the Middle East and the Far East, while erlotinib, which came later, is approved in the United States. So it makes it work better. So again, the mutation, what it does is a driver of the tumor. So these particular agents, what they do is they go after the driver. So they really perfectly dock against the driver. So again, the boss cannot move on since the driver is completely out of the picture. So it's interesting. There are two different things. So with the EGFR mutations, these patients appear to have a better prognosis even without treatment. So that means that they tend to live longer even if you did not give them treatment or if you give them chemotherapy. So it is not a bad prognostic factor. It's actually a good prognostic factor, but also it is a predictor because these agents selectively, exquisitely work on this, and you get responses that are very, very long lasting. So it really does prolong your life, even that it is not a bad prognostic factor when you compare it to the general lung cancers. Now, on the other hand, KRAS, it is an oncogene. Normally, you have it in the membrane sitting in there, and it turns on and off. And when you have the mutation, this oncogene is on all the time. And it sends signals down into the nucleus of the cell, so the cell will do bad things and multiply, divide, metastasize, etc. So it is a bad prognostic factor. And unfortunately, it is not a good predictor because we don't have good therapies yet for patients that have mutations in the KRAS. We're working on some, and we have some experimental approaches. But we do not have approved therapies that are very good, and it appears to be a bad prognostic factor for patients that do not get treatment or for patients that get treatment with traditional agents.